Welcome viewers. Today's topic is congenital heart disease. Congenital heart disease can be the result of defects in the formation of the heart or blood vessels, or can arise because the anatomical changes that occur during transition between the fetus and the newborn child fail to proceed normally. Congenital heart disease usually presents in childhood, but some patients do not present until adult life. It has been estimated that the incidence of hemodynamically significant congenital cardiac abnormalities is about 0.8% of live births. Defects that are well tolerated, such as atrial septal defect, may cause no symptoms until adult life or may be detected incidentally on routine examination or chest X-ray. Congenital defects that were previously fatal in childhood can now be corrected, or at least partially, so that survival to adult life is the norm. Such patients remain well for many years but subsequently represent in later life with related problems such as arrhythmia or heart failure. Now, the incidence and relative frequency of congenital cardiac malformation. This table shows the incidence and relative frequency of congenital cardiac malformation. Here we can see the ventricular septal defect is more common, about 30% of all congenital heart defects. So ventricular septal defect is more common. Then atrial septal defect, its frequency is 10%. Persistent ductus arteriosus or PDA, its frequency 10%. Pulmonary stenosis, frequency 7%. Coarctation of aorta 7%. Aortic stenosis 6%. Tetralogy of Fallot 6%. Complete transposition of great arteries 4%. And others congenital heart disease is 20%. Now, what are the presentation of congenital heart disease throughout life? The presentations are: in birth and neonatal period, it is cyanosis and heart failure. In infancy and childhood, there is cyanosis, heart failure, arrhythmia, murmur, failure to thrive. In adolescence and adulthood, the clinical features or presentation are heart failure, murmur, arrhythmia, Eisenmenger syndrome, hypertension. In coarctation, complications of previous cardiac surgery, as like arrhythmia related to scarring, heart failure secondary to scarring. Now, the pathophysiology of congenital heart disease. Understanding the fetal circulation helps clarify how some forms of congenital heart disease occur. The figure shows the fetal circulation and the changes that normally occur immediately after birth. In the fetus, there is little blood flow through the lungs, which are collapsed because they are not required for gas exchange. Instead, oxygenated blood from the placenta passes directly from the right atrium to the left side of the heart through the foramen ovale without having to flow through the lungs, and also from the pulmonary artery into the aorta via the ductus arteriosus. During early embryonic life, the heart develops as a single tube that folds back on itself and then divides into two separate circulations. Failure of septation can cause some forms of atrial and ventricular septal defect. Again, I am telling, failure of septation can cause some forms of atrial and ventricular septal defect, whereas failure of alignment of the great vessels with the ventricles contributes to transposition of the great arteries, tetralogy of Fallot and truncus arteriosus. Atrial septal defects occur because the foramen ovale fails to close at birth, as is normal. Similarly, a persistent ductus arteriosus will remain persistent if it fails to close after birth. Failure of the aorta to develop at the point of the aortic isthmus and where the ductus arteriosus attaches can lead to coarctation of the aorta. Maternal infection and exposure to drugs or toxins are important causes of congenital heart disease. So I am again repeating, maternal infection and exposure to drugs or toxin are important causes of congenital heart disease. Maternal rubella infection is associated with persistent ductus arteriosus, pulmonary valvular and or artery stenosis, and atrial septal defect. Maternal alcohol misuse is associated with septal defects, and maternal lupus erythematosus with congenital complete heart block. Genetic or chromosomal abnormalities such as Down syndrome may cause septal defects, and gene defects that have also been identified as leading to specific abnormalities such as Marfan syndrome and DiGeorge syndrome, where deletion in chromosome 22q. Now, the clinical features of congenital heart disease. The clinical features are: symptoms may be absent, or the child may be breathless or fail to attain normal growth and development. Some defects are not compatible with extrauterine life and lead to neonatal death. Clinical signs vary with the anatomical locations. Murmurs, thrills, or signs of cardiomegaly may be present. In coarctation of the aorta, radiofemoral delay may be noted. And some female patients have the features of Turner syndrome. Features of other congenital conditions such as Marfan syndrome or Down syndrome may also be apparent. Cerebrovascular events and cerebral abscesses may complicate severe cyanotic congenital disease. Early diagnosis is important because many types of congenital heart disease are amenable to surgery, but this opportunity is lost if secondary changes such as irreversible pulmonary hypertension occur. This diagram showing radiofemoral delay. Here the difference in pulse pressure is shown. Now, central cyanosis and digital clubbing. Central cyanosis of cardiac origin occurs when desaturated blood enters the systemic circulation without passing through the lungs, that is right to left shunting. In the neonate, the most common cause is transposition of the great arteries, in which the aorta arises from the RV and the pulmonary artery from the left ventricle in association with a ventricular septal defect. In older children, cyanosis is usually the consequence of a ventricular septal defect combined with severe pulmonary stenosis, as in tetralogy of Fallot, or with pulmonary vascular disease, that is Eisenmenger syndrome. Prolonged cyanosis is associated with finger and toe clubbing, growth retardation, and learning difficulties. These may occur with large left to right shunts at ventricular or great arterial levels, and also with other defects, especially if they form part of a genetic syndrome. Major intellectual impairment is uncommon in children with isolated congenital heart disease. Minor learning difficulties can occur, however. Cerebral function can also be affected after cardiac surgery if cerebral perfusion is compromised. Syncope. In the presence of increased pulmonary vascular resistance or severe left or right ventricular outflow obstruction, exercise may provoke syncope as systemic vascular resistance falls, but pulmonary vascular resistance rises, worsening right to left shunting and cerebral oxygenation. Syncope can also occur because of associated arrhythmias. Pulmonary hypertension. Persistently raised pulmonary flow with a left to right shunt causes increased pulmonary vascular resistance followed by pulmonary hypertension. Progressive changes including obliteration of distal arterioles. Progressive changes including obliteration of distal arterioles take place and are irreversible. At this stage, central cyanosis occurs and digital clubbing develops. The chest X-ray shows enlarged central pulmonary arteries and peripheral pruning of the pulmonary vessels. Again, I am saying peripheral pruning of the pulmonary vessels. The ECG shows features of right ventricular hypertrophy. Now, the Eisenmenger syndrome. In patients with severe and prolonged pulmonary hypertension, the left-to-right shunt may reverse, resulting in right-to-left shunt and marked cyanosis. This is termed Eisenmenger syndrome. The cyanosis in Eisenmenger syndrome may be more apparent in the feet and toes than in the upper part of the body, resulting in so-called differential cyanosis. Again, I am telling, the cyanosis in Eisenmenger syndrome may be more apparent in the feet and toes than in the upper part of the body, resulting in so-called differential cyanosis. Eisenmenger syndrome is more common with large ventricular septal defects or persistent ductus arteriosus than with atrial septal defects. Patients with Eisenmenger syndrome are at particular risk from abrupt changes in afterload that exacerbate right to left shunting, such as vasodilatation, anesthesia, and pregnancy. Congenital heart disease in pregnancy. During pregnancy, there is a 50% increase in plasma volume, a 40% increase in whole blood volume, and a similar increase in cardiac output. So, problems may arise in women with congenital heart disease. Many with palliated or untreated disease will tolerate pregnancy well, however. Pregnancy is particularly hazardous in the presence of conditions associated with cyanosis or severe pulmonary hypertension. Maternal mortality in patients with Eisenmenger syndrome is more than 50%. Pregnancy in women with congenital heart disease. There is obstructive lesions, poorly tolerated and associated with significant maternal morbidity and mortality. Cyanotic conditions, especially poorly tolerated, specialized preconception counseling should explain the increased risk. Surgically corrected disease, patients often tolerate pregnancy well. Children of patients with congenital heart disease, 2 to 5% will be born with cardiac abnormalities. 2 to 5% will be born with cardiac abnormalities, especially if the mother is affected. The risk may be up to 20% in babies born of women with left-sided lesions. These two diagrams showing the circulation of baby. First, diagram A shows fetal circulation in the intrauterine life. There is presence of umbilical vein, umbilical artery, and ductus arteriosus, ductus venosus, and open foramen ovale. And the right figure shows, figure B, it shows the circulation after birth of the baby. Here shows closed ductus arteriosus, closed foramen ovale, ductus venosus closes, and umbilical arteries also closes. Now the changes in the circulation at birth. The figure A shows in the fetus, oxygenated blood comes through the umbilical vein where it enters the inferior vena cava via the ductus venosus. The oxygenated blood streams from the right atrium through the open foramen ovale to the left atrium and via the left ventricle into the aorta. Venous blood from the superior vena cava crosses under the main blood stream into the right atrium and then partly mixed with oxygenated blood into the right ventricle and pulmonary artery. The pulmonary vasculature has a high resistance and so little blood passes to the lungs. Most blood passes through the ductus arteriosus to the descending aorta. The aortic isthmus is a constriction in the aorta that lies in the aortic arch before the junction with the ductus arteriosus and limits the flow of oxygen-rich blood to the descending aorta. This configuration means that less oxygen-rich blood is supplied to organ systems that take up their function mainly after birth. Example in kidneys and intestinal tract. In figure B shows at birth the lungs expand with air and pulmonary vascular resistance falls. So that blood flow now flows to the lungs and back to the left atrium. The left atrial pressure rises above the right atrial pressure and the flap valve of the foramen ovale closes. The umbilical arteries and the ductus venosus close. In the next few days, the ductus arteriosus closes under the influence of hormonal changes, particularly prostaglandins, and the aortic isthmus expands. Thank you all.